Additionally, I want to mention some more measurements of findings when it is enough water. When the coronary sinus is dilated, that is a hint to hypovolemia or also elevated pressures. A dilatation also over time of the right ventricle and the right atrium, a reduction in strain imaging in the follow-up is definitely pointing towards more and more volume overload, especially the size of the right ventricle. The no more changing of stroke volume and the LVOT points towards hypervolemia, so enough fluids. The raising filling pressures, the raising E to E prime, the E elevation, the E to A, which is then above 2, and many more signs from the evaluation of diastolic dysfunction. Of course, a patient who has edema, signs of heart failure, and the B lines. This is the pulmonary venous signal. You place a pulse wave Doppler in the pulmonic vein. Also, if you have here a S signal and the D signal, and the S signal is smaller than the D signal, that also points towards elevated filling pressures, pointing towards, in this case, also hypervolemia. Elevation of left ventricular filling pressures and of course left atrial pressures. Here is no mitral stenosis present. Here you also see another wave, that's the so-called AR, so a flow reversal after the D wave, also indicative of elevation of filling pressures. There are some pitfalls. In this case, the coronary sinus dilatation was not due to hypervolemia. This is a persistent left superior vena cava. So you administer a milliliter of blood, half a milliliter of air, and 7 to 8 milliliters of a crystallid, for example. And if you administer it in the left arm, you see the flow coming from the persistent left superior vena cava. Take a close look over here and you see the bubbles entering, and this truly then is the proof that this is the persistent left superior vena cava and not pathological dilatation of the coronary sinus. So you need right heart contrast, blood, agitated saline, and a little bit of air, and a fast administration in the left arm. This is a multiplane view once more for you to see the severely dilatation of the coronary sinus and this nicely administered right heart contrast. The pulmonary venous signal is not always easy. You need good image quality, you need an optimal signal. And of course, there are pitfalls like severe mitral regurgitation. There you also have this flow reversal in systole, indicative of either severe mitral regurgitation or elevation of filling pressures. And here you see the flow reversal due to this eccentric primary mitral regurgitation, which was then of course severe. You can also measure the IVRT of the right ventricle. It's a TDI S prime measurement, which you normally know, and you have the S prime and then you have the E prime and A prime of the right ventricle. And if you have a prolonged IVRT of the right ventricle, so the S prime and then the IVRT, the isovolumic relaxation time of the right ventricle, above 65 to 70 milliseconds, shows elevation of filling pressures or pulmonary hypertension as an additional measurement. But keep in mind, you have to use this measurement very often to feel secure and measure it correctly. These specific measurements and also these pathological findings you have with the tissue Doppler, you can take a look in the brand new video on diastolic dysfunction, which will be posted very soon, where we'll discuss also rarely used measurements to evaluate if there are elevated filling pressures of the left ventricle, the left atrium, or the right ventricle and the right atrium present. Here you have several signals, and you see here is a pathological IVRT, it's prolonged. Here it is normal, so there's almost no IVRT of the right ventricle seen. This is also a case of a normal IVRT with an optimized signal where you can nicely see that this is almost towards zero. So the E prime diastasis, A prime, the IVCT, the isovolumic contraction time. If you go to the signal, that's the isovolumic contraction time, the S prime, which is normal, and then basically no real IVRT of the right ventricle. Keep in mind the gallbladder wall. You can also scan if the gallbladder wall is thickened. That could be edema, that could be to ascites, in this case liver cirrhosis, but of course that also could be due to venous congestion because of heart disease. I also want to mention, because I truly love strain imaging, you can use left atrial and right atrial strain to differentiate if there are elevated filling pressures present. In this case, the LASR, the left atrial strain, the reservoir strain is only 3%, which is clearly an elevation of filling pressures. So you see the reduced left ventricular function, dilated right, dilated left ventricle, calcified valves, severely dilated atria. Here you have a pacemaker lead. So left atrial strain can help you to differentiate left atrial filling pressures. Right atrial strain can show you reduced right atrial filling pressures. Here you have a normal curve, ASR, so the right atrial strain, the reservoir phase. We have a conduit phase, which is this falling until the pre-A, so before the P wave, which is then the contraction, the RASCT. It's also the LASCT, the LAS conduit, the contraction phase, and the conduit phase, of course, here is atrial fibrillation present. You cannot measure. This is a normal signal with no pulmonary hypertension present, with no elevation of filling pressures present, in this case with normal right atrial function. An outtake I want to present you, there's a patient in the emergency department. The patient has elevation of BNP levels, so NT-proBNP is mildly elevated, and there's a large pleural effusion, and this has to be a patient for the ICU. This patient needs hemodynamic monitoring due to this huge pleural effusion. The pleural effusion was one-sided, so it was only on the left side, which is not per se a cardiologic cause where you think immediately about the heart. Here you see a complicated pleural effusion with a lot of strands inside. So this was a patient where the suspicion was that this is either cancerous or severe infection, for example, empyema. Overall, this patient was respiratory stable, and it turned out to be a carcinosis of the lung and also the diaphragm. Here you see a consolidation, a complicated pleural effusion. Here you see these multiple fibrinous strands, these complicated effusions. Here you cannot relieve the fluid properly. So this is a patient who primarily I wouldn't think about the heart as a cause of this complicated effusion. So if you see such an effusion, this is most likely inflammation or, on the other hand, a malignant disease.